Dr. Akemi, can you hear me? Are you ready?
Yes, I can hear you very well. Yes. Thank you very much. I can
All
hear
right.
you.
Okay, good. So good morning, good afternoon, everyone. I'm delighted to come to today's grand rounds. I'm chair of surgery at the Lagos University Teaching Hospital. Stakeholders joining us from around the world today. A mix of neurosurgeons, radiologists, neurologists, hospital administrators here in Louth and elsewhere. This bi-monthly for the last going on 2 years now. The title of today's grand round is From the Brain to This. Before I introduce today, housekeeping rules, please mute your mic to join the center. And if you are sharing your video, what is in your background. But we'll definitely write them out. So just give us time if that happens. At the end of the presentation, we'll have the opportunity to ask when Q&A, then you can use the hand raise motion. Our moderator today is Dr. Henrik Ullman. Dr. Ullman is a diagnostic and interventional neuro and assistant professor at the Department of Radiology, University of New Mexico School of Medicine. He received his medical at the Karolinska Institute of Medicine, a famous institute, and he also has a PhD from the predicting development in MRIs. He has received several awards and grants and has published several papers in peer-reviewed journals, presented at national and international conferences. He will be moderating the session. Is Dr. Board Certified Diagnostic Practice of Pittsburgh Medical Center, Susquehanna, with Chief and Medical Director of Interventional Radiology at the UPMC. He has championed clinical research and medical education, ensuring cutting-edge care and knowledge dissemination. Dr. Akinyemi was born and raised in Lagos, school into the US. That's where he departed, and he obtained his from New Jersey Institute of Technology. He completed his medical degree at the Medical College of Wisconsin, and he then University of Syracuse. He then underwent another residency in diagnostic radiology at the Bridgeport Hospital under the Yale University program in Connecticut, and he completed his vascular and interventional radiology fellowship at Pennsylvania State University in Hershey. Dr. Akinyemi has worked as the medical director and instructor at Trenton, New Jersey. He's also worked as an interventional radiologist at the Lord's Imaging Associates in Camden, also in New Jersey. He has contributed peer-reviewed articles and presentations, recognitions, and awards. He's currently a medical director of interventional radiology at Independence Health, Pennsylvania, and the co-founder of the Society of Interventional Radiology and Endovascular Sapphire. He's happily married, beautiful children. So I'm going to hand over to Dr. Akinyemi now. Take talk. Thank you very much, Dr. Akinyemi. Over to you.
Yeah, thank you very much, Professor Bankole, for inviting me. Thank you, Dr. Holman, for being the moderator here today. I truly appreciate your time this morning. Let me see if my slide works. So I have no disclosure. So my talk today will basically center around interventional radiology. It's a general talk, but there are some specific areas that we will delve into. I know that this is a mostly neurosurgery and neurology audience, but there are other things that we'll talk about, as the topic implied, you know. Radiology in general, is the subspecialty of diagnostic radiology. But over time, it's become its own independent medical specialty. We perform several procedures using minimally invasive techniques. We use, general modalities such as CT, X-rays, ultrasound, and MRI guidance to access, you know, pretty much all parts of the human body at this point. We perform interventions. Um, we're very, very technology based, and IR is one of those specialties that embraced. I would say radiology is one of those specialties that embraced technology very, very early, and now many of our procedures, you know, includes, many, many things that used to be performed by very invasive surgeries that we now do, basically using our minimally invasive techniques. And I'll get into some of those as we move along. This screen here is actually the most important slide, and everything we're going to talk about is going to be based on this screen here. So we perform several interventions, basically from the brain to everywhere else. There are interventional radiologists who perform um, neural procedures such as, aneurysm coiling and stenting of the intracranial arteries, thrombectomies, treatment of strokes in the brain, carotid artery stenting. We do a lot of aneurysmal repair also in, different parts of the body, in the chest, abdomen, and pelvis. Aortic aneurysm is one area that we also work on, although we do share some of these procedures with some of our other colleagues, for example, vascular surgery surgeons and interventional cardiologists. We do a lot of cancer treatments. As a matter of fact, there's another specialty which is sort of developed from IR, which is now called interventional oncology, where they basically focus on treating malignancies. We play a critical role with regards to internal bleeding, whether the bleeding is from the GI tract, whether it's from, traumatic injury to the spleen, for example. We would perform angiography, look for what's bleeding, and then embolize it and block the bleeding. We are involved with several urological procedures where we place nephrostomy tubes. We do ablations for, kidney cancers, liver cancers. We are very involved in dialysis work as well. From, in the past, it used to be that the vascular surgeon would create the dialysis AV fistula circuit, and we would intervene by, removing the clots or doing some venoplasties and this and that. But nowadays, we actually create the fistulas ourselves by basically accessing an appropriate vein and appropriate artery in the upper extremity and looking for areas where where the veins and artery actually close together. And then we basically there are several devices on the market now that you can actually use to basically burn a hole between an appropriate artery and appropriate vein. Typically, it's going to be radial artery and ulnar artery, or you basically anastomose them with whether it's the cubital vein in the elbow region. So we're very involved with that. We do intervene in the bone and spine, particularly for IR. We do a lot of bone biopsies. We do a lot of bone ablations now in people who have metastatic, both primary and metastatic bone malignancies. In some cases, when people have fractures these bones due to malignancy, or whether it's even due to trauma, we would actually go in and put a balloon in the bone and, help increase the height of the bone and then inject cement. And, we refer to that as kyphoplasty, as you guys are very, very familiar with. This is an example of a patient who had traumatic descending aortic pseudoaneurysm, which was covered with a covered stent. And the patient did also have, as you can see, uh, left subclavian to carotid artery bypass by the vascular surgeons. So what you see is that, I mean, the theme of these talks that, we're very, very collaborative. We work with basically every medical specialty that you can think of. There's usually something for everyone. Um, so in terms of the scope of interventional radiology, is very, very wide, as I alluded to. Um, can you see my mouse here?
Yes.
You can see my mouth, very good. So I'll give you an example. So this is a patient who has, this is an angiogram of the liver, actually. This is a patient who has, this is the liver on angio. You can see this patient has multiple liver masses that we can see. You can see the areas of abnormal enhancement. And what we do with the liver masses is sometimes we would go in and basically embolize the feeding vessels to these liver malignancies. Sometimes we actually would inject chemotherapy or radiation material into that area so as to isolate the lesion and then, and provide local directed treatment so the patient does not suffer from a lot of, the typical systemic chemotherapy, side effects. These procedures help to, extend life. And in many cases, many of these patients end up going for transplant. So we keep them alive long enough so that they can get the transplant. As the audience knows very well, the real cure for many of these malignancies in the liver will be liver transplant, you know. So we also, I would say, glorified plumbers in a way because we open up blood vessels, we put in stents. This is a patient who has occluded common iliac, external iliac artery that we were able to recanalize and place stents. And now the vessel is patent. As I alluded to earlier, we work in the renal space with our urologists and our nephrology colleagues. We place nephrostomy tubes. Sometimes we would actually go from the kidney and then put a double J stent and then remove the nephrostomy tube completely so that patient can still have a drainage without a catheter sticking out of their backs. We do a lot of work in the bleeding area, and I think I have other slides as well that show some embolizations that we performed in patients who were actively bleeding. This is an example of a patient with subclavian steal syndrome who had reversal of flow within the left vertebral artery. Here you can see there's a catheter, there's a PTO catheter within the ascending aorta that's showing filling of the vessels. I don't have the pre-images, but this is a post-image demonstrating placement of a stent within the left proximal left subclavian artery. Follow-up ultrasound demonstrated, normal antegrade flow within the vertebral artery, and the patient still syndrome phenomena, or like basically all the symptoms resolved. Just to highlight that we also are involved in the aortic aneurysm space in conjunction with, in the past, this was mostly done by interventional radiology in the US, but now it's either done by vascular surgery, cardiology, or a combination of IR and all those other specialties. In general, IR is one of those specialties where you can do everything, but at the same time, you basically do whatever you're it depends on, the region of the country where you work, the region of the world. In the US where we have um, so many medical specialties in this space, many times we make agreements with other departments and basically we divide and say, okay, you guys will do the venous cases, we'll do the arterial cases, and that's sort of how it works here. As I alluded to, we treat cancers in different ways. Sometimes we perform ablative therapies, which is we basically put a probe in the cancerous lesion under CT or ultrasound guidance, and we can burn the lesion by using radiofrequency ablation techniques. We can microwave the lesion. We basically cook the lesion and kill it. The other thing that we also do is that we also would inject sometime localized chemotherapy or radiation beads into the lesion so that this actually treats the lesion locally, and the patient does not have you know, lots of systemic side effects. We provide a lot of drainage catheters. We insert stents everywhere. We we insert lines for chemotherapy. We place Mediports and peripheral inserted central catheters, chemotherapy ports, in addition to other things. This is an example of a patient who underwent ablative therapy. This is a CT of the abdomen without contrast. This is the axial series. You can see there's an ablative needle coming from the right side of the patient, going into a posterior liver lesion, which is not very well seen here, not projecting very well. And to be honest, this is the same technique that we would use to do biopsies, for example. So what we would do, like typically we're part of a cancer center and the patient gets referred to us, the patient comes in. If we then we basically go using the same techniques to get a biopsy of the lesion. And many times the patient comes back and then we would go in and ablate the lesion, whether using heat, which is basically microwave or RF ablation, or we would use, cryoablation, which is basically using extreme cold to destroy the lesion and induce apoptosis. In some cases, we do combination therapies where we will actually burn the lesion and also do an arterial intervention where we also are going through the blood vessels that supply the lesion and inject material to actually completely block it off. And many times when you do these combination therapies, you actually get better results compared to when you only do single therapies for these patients. And a lot of time, some of these patients are not, they're not surgical candidates. Some of them, the lesions are so big that, they can't really undergo, they do not meet the transplant criteria. And the procedures that we perform do not only extend life for these patients, they increase quality of life. And in some cases, as I said earlier, they keep them alive until they can get the appropriate transplant. Now, in cases of people who have like renal cell cancers and things, we can actually cure those for sure. If the liver mass, depending on the size, sometimes we can actually cure these liver masses and they don't actually have to have any surgery or any further procedures. We just do sort of surveillance imaging and watch this patient and kind of sort of see how they do. And we also work very closely with the oncologists to, follow the patient's, tumor markers, follow their imaging and make sure that things are kind of stable. We do a lot of GI bleeding, just bleeding in general. I'll show you some images of some procedures that one of my colleagues performed. I don't think I did this particular one there, but this patient had bleeding from a distal SMA branch. I think this is more closer to the ileocholic artery. You can see there was bleeding earlier on, but this image was performed post-embolization. You can see this coil material, which is actually blocking any distal, blocking the site of bleeding, and the patient now has no further evidence of bleeding. And these procedures are very neat. A lot of times we get a CT angiogram of the whatever area that's bleeding ahead of time, because this helps us localize the exact place where the bleeding is occurring. So we basically go and select that area, and then once we find the exact area, we inject the material and then block the artery. So I sort of talked about many of this already. We play a very key role in, as I said earlier, like vertebral body fractures. This is a patient who underwent kyphoplasty procedure for these vertebral compression fractures. this is a patient who had a left-sided IJ dialysis catheter placed. This is a patient who has pancreatic malignancy that's obstructing the intrahepatic bile ducts. A lot of times these patients are seen by gastroenterology colleagues first. They go in and do their ERCP, and then they try to place a stent. But there's some times when, you know, the lesion is too big, or they can't get their scope around, and then they call us, and then what we do, and we do an antegrade approach where we actually isolate the biliary duct under ultrasound or fluoroscopic guidance. We access it, and then we place a drain, and so that the patient can drain to the outside. And sometimes we just internalize we place an internal stent, and we do this a lot of times in patients that don't have that much time to live. Patients who have, let's say, patients who we know would not be around, you know, after 6 months or so. What we do is that we place an internal stent, and this allows the bile ducts to be able to internally drain. And this really helps a lot in terms of the patient's quality of life. I mean, you see these patients out there, you know, completely, you know, very yellow, and they have a lot of itching. So when you place the stents, this helps improve the quality of life pretty greatly. And we have some slides later on about fibroids. We play a very key role in women intervention, especially with regards to fibroids. And I have some slides, and I'll get into that a little later in the talk. So the entire specialty was invented by one man. He was a Swedish radiologist. I think back in the 40s, when he was a medical student, he figured out what we basically now call the Seldinger technique. His name was Ivor Seldinger. And the technique is basically simple. The technique is that if you want to get into a blood vessel, for example, if you can get a small, tiny hollow needle into the blood vessel, and then put a wire through it, right? And then remove the tiny needle, and then put a catheter through it, right? That you can basically do, you know, many things that you want to do through that catheter. This was a very, I mean, this basically changed the world of medicine, this simple technique. And it's basically the origin of many, many specialties that we see today. Interventional radiology, interventional cardiology, interventional neuroradiology, vascular surgery, so many specialties have now adopted this technique. And I can tell you that in interventional radiology, everything, literally everything that we do is basically based on this simple technique. So, and what I mean by that is that, you know, let's say we want to, you know, go into a blood vessel and do an angiography or an intervention. What we first do is that we get access through a needle, right? Once we're in the blood vessel, we put a wire through it. And once, oh, I guess the light just turned off here. I'm just going to turn the light on real quick. So, okay, it's back on. So once we are in the blood vessel, we get a wire in, we remove the needle, we put a catheter in, and through this catheter, we perform all of our interventions, whether it is angioplasty, venoplasty, as a matter of fact, whether it is biopsies, everything that we do is based on this simple technique. It's an example of a patient who underwent biopsy of a right upper lobe lung lesion. This is a CT of the chest without intravenous contrast. We usually place a marker on the skin, and so that helps us sort of isolate exactly where we're going into. We look obviously for blood vessels, make sure that we're avoiding any blood vessels or, you know, nerve bundles, and we'll put the needle directly into the lesion and just get some samples out. And this is the same exact technique that we would use for ablations, for example. The only difference between a biopsy and any ablative techniques, any ablative procedure we perform, is the size of the needle and the functionality of the needle. So if you were doing, let's say it's a cryoablation where we use extreme cold or radio frequency or microwave ablation, it's the same exact technique that we use. The only difference is the size of the needle. And you can see that this is still based on that Seldinger technique that I just highlighted. We perform lots of biopsies. We do ultrasound biopsies, percutaneous biopsies. But the reason I included the slide is that we also perform a lot of transvenous biopsies. For example, if we wanted to perform a biopsy in the liver and the patient has, let's say they're very large and they have big body habitus and they, or we're very worried about the bleeding. Sometimes what we would actually do is that we go through the internal jugular vein and we actually go through the, right atrium, get into the IVC, we get into the hepatic veins, and then we actually put a needle directly from the IJ, internal jugular vein, into the hepatic veins, and then we actually get samples out directly from that. And the advantage of this technique is that there's really no risk of bleeding as long as you don't violate the the liver capsule. And the patient were to bleed in the liver, they're going to bleed into their own blood vessels. And all that's required afterwards is that to just hold pressure on the jugular vein for maybe 3 minutes, and bleeding stops. Now, one area that we also provide a lot of help is for patients who have liver cirrhosis, who have developed portal hypertension, who have elevated portal pressures. These patients are very, very big part of our, I would say, many, many interventional radiology practices in the US. Because what we're able to do in this patient is that we are actually able to treat their portal hypertension. And I'm going to go through this in a little bit more detail. Let's see here. Well, let's see if everyone remembers this image from Frank Nera anatomy from, I don't know, first year of medical school many, many years ago. This image basically shows the portal anatomy. Just a quick review, all the blood in the gut in the GI tract is drained by the portal vein. The superior mesenteric vein, inferior mesenteric vein, they all drain through the main portal vein, right? The portal vein provides majority of blood supply to the liver, right? And then the portal vein through the sinusoids communicates with the hepatic vein, right? And then everything goes through the IVs, the hepatic veins into the inferior vena cava, and blood gets returned to the right atrium, and and then circulation continues and repeats all over again. The problem with people with liver cirrhosis is that they have, whether due to infection, disease, or due to alcoholism, they've destroyed their sinusoids within the liver. So what then happens is that blood tries to get into the liver, it faces a lot of resistance. Because of the resistance, the pressure in the portal vein increases, and the blood tries to find a way to try to get into the right atrium by any means necessary. And then what the body then does is that it creates all these varices, abnormal veins, which we call varices, and they go around the esophagus. That's why a lot of these patients, they end up coming in with GI bleed. Sometimes the varices actually they create varices around the rectum. They come in with rectal bleed, and the entire reason why this happens is that blood is doing everything possible to. The body is doing everything possible to get blood back into the liver and into the right atrium, and to provide blood to the heart and every other organ. So, what the key role that the interventional radiologist plays in this particular scenario is that we can actually provide a shunt between the portal system and the portal system and the systemic veins. And then when you actually provide the shunt, this allows blood to flow directly from the portal system into the systemic circulation. And as you know, what would happen is the blood will then go through the path of least resistance, and the varices will close up, and the patient's symptoms regarding, abnormal bleeding and all these things usually would resolve. And this procedure is very critical because not only does it stop the bleeding, it extends patients' lives, and we also do this a lot of times as a bridge to transplant. In many patients, however, who are not candidates for transplants, or in many countries where liver transplant is not available, this procedure is very key because what it does is it actually helps extend the patient's life for many, 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 many years. We've had patients who couldn't get transplant for 7 years, or who are not candidates for transplant, and we just we place the stents, and then we keep these patients alive for a very, 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 very long time, and we also keep them symptomatic free, meaning that they don't come in with, massive upper GI bleeds anymore. The abdominal ascites many times would resolve. And I'll show you a case that we performed. So this is just showing cirrhosis and what happens with liver cirrhosis. I'm just going to skip this. So in the past, before we came up with this, before IR came up with this liver shunts, there are many surgical shunts that were performed before. I mean, some of these surgeries have a mortality of greater than 60%. I think in the US, I don't even think anyone performs them. And you read case reports of some of these surgeries being performed maybe at centers like Johns Hopkins, but it's very, very rare that people would perform these surgeries these days, given that there are now alternatives. Um, and this is what the shunt looks like. So basically, we provide a connection between the portal vein, which is draining the portal circulation, and then connect it to the intrahepatic hepatic veins, and this allows blood return to go from the portal to the systemic circulation without uh, uh, this definitely works very well. It has its own downsides, which we can get into a little bit, but I'll show you a few cases that we did here. So I had a 77-year-old referred to me a couple of years ago. He had liver cirrhosis, portal hypertension. He has had several episodes of, esophageal bleeding and, rectal bleeding. Because of his age, he was 77 years old. He was not really enthusiastic about going through a transplant procedure. Neither would he be qualified um, for a liver transplant, which is the only cure for liver cirrhosis, anyways. So we brought him down to the interventional radiology suite. This is the angio that we performed. I went in through his right internal jugular vein. I had my catheter through his right atrium into the right hepatic vein, and we put a needle through the catheter, right? And then we basically stabbed the liver anteriorly. And then when you stab the liver, you basically then pull back a little bit. And once I saw that there was some blood, I did an injection. And this injection actually delineates the patient's portal vein, anatomy. So once I knew that I was in the portal vein, the next thing I did was to put a wire through from the systemic circulation to the portal system and then place the stent. So this is the post-procedure imaging where you have the portal vein filling here, and you've got the right atrium filling here. You've got a catheter going from the basically right into the jugular vein, going into the hepatic vein, going to the liver parenchyma, then going to the portal vein. There's a stent here. I don't know if it projects very well. And what we did afterwards is, before and after we checked the pressures within the portal vein, you check it before and after, and we saw that there was a drop in pressure, as expected. And the result of this was that the patient's symptoms completely went away. He didn't have encephalopathy. And one of the disadvantage, I guess the advantage here is everything that we talked about already. One of the disadvantages is that now you've got blood that's not been filtered through the sinusoids of the liver, now going into the right atrium and into the systemic circulation. And of course, what happens is that, these patients would sometimes experience confusion, encephalopathy. They have things like asterisk and it doesn't happen all the time, but when this happens, we rely on our GI colleagues to help treat the patient with, lactulose or, rifampin or the most updated medical therapy available. And this actually helps to treat this condition. And these patients do very well. So I get into the oncology parts a little bit. We do a lot of interventional oncology as well as part of our practice, from biopsies to placement of Mediport to embolization ablations, as we talked about earlier on. Sometimes we also perform palliative procedures, and one of the palliative procedures we perform is kyphoplasty and bone tumor ablation, as I mentioned earlier on. There are some interventional radiologists now who are now performing a lot of spinal cord stimulators, all these dorsal column stimulators to help alleviate pain. in patients who have intractable pain, whether it's from cancer or, other diseases. So basically in the liver, kidney, in the bones, we basically perform the same exact procedures. And I don't know, this talk might sound slightly repetitive because pretty much IR is a very, very, it's a very, very involved specialty. But a lot of time, what you see, the thing is that you see that we just basically do the same exact things in different organs. And that's why you see me talk about embolization in the liver, in the kidney, ablations in the liver and the kidney. It's basically the same equipment that we use. It's basically the same probes that we use. And this procedures work very well and patients do very well. Liver cancer is very, very, especially HCC is very common in the US now. In the past, back in the days, it used to be caused by people who are drug users, but now we've seen we've seen a rise in people who are obese, who have non-alcoholic fatty liver disease or non-alcoholic, steatohepatitis, which is called NASH. So we've seen a lot more of that. And again, these are the patients who come to us for these therapies now, for the chemoembolization, for the radioembolization, which basically means that we, instead of using chemotherapy beads and putting them into these arteries and blocking them off and providing local regional therapy to that area, we also use basically yttrium is the material that we use. We actually load this onto beads and then we inject that, and that actually provides local radiation therapy to that area, to that lesion. Again, this is a bridge to transplant. This helps extend life. As you know, the liver, the liver is mostly supplied by the portal vein. I think 80% of the supply is from the portal vein. The hepatic artery supplies maybe about 20%. It turns out that most of the liver cancer, HCC, actually supplied by the hepatic artery and not the portal vein. So that's why we can actually take out the hepatic arteries, branches of it, and not worry about having any sort of liver necrosis, because to begin with, the hepatic artery in general only supplies about 20% of the entire blood supply to the liver. So when we embolize the hepatic artery branches, we're not as worried about liver necrosis or things like that. Although in patients sometimes who've had portal vein thrombosis, those kind of things, sometimes you worry about that, but a lot of time it's really not an issue. I think we talked about chemoembolization and radioembolization briefly. I'm going to just talk to you about a patient that I had, 47-year-old female who had multiple metastatic lesions in the liver, neuroendocrine tumor. So you can see this is a contrast-enhanced CT that shows some enhancement within the right lobe of the liver. These are really large masses. You can see them better on the MRI. The patient had a PET imaging, which is when they inject FDG into the blood vessels, and this shows activity within the liver, which is abnormal. The activity within the spleen is probably mostly normal, but this is very abnormal here. The MRI of the abdomen with contrast demonstrates multiple enhancing lesions within the liver here. So the patient initially came, we went in, I put my needle in. You can see my needle going through the liver capsule to get some biopsies, so that we could tell what the diagnosis was in this case. It's another MRI. So after we diagnosed the patient with metastatic neuroendocrine tumor, what we did was I took the patient to the angio suite. I went into the right femoral artery, got my catheter into the aorta, and did a flush aortogram, which is just showing the anatomy of the patient. And then I ended up selecting the celiac artery and navigating my way. This is the celiac origin here. This is the hepatic, common hepatic artery. This is the gastroduodenal artery. This is the hepatic proper artery, and this is the right hepatic artery. And now I did some more selective injection that actually shows the enhancement of the tumor. You can see that on sort of delayed imaging here, where you can actually see some of the tumor enhancement. The patient had multiple tumors. And then once we did was that once we were able to isolate the exact artery supplying the tumor, we just basically injected chemotherapy beads into the lesion. And what this does is that it basically blocks the blood supply, and also the chemotherapy agents are then trapped within the lesion, and then then the chemotherapy is then delivered over time to the patient. This patient in particular actually did very, very, very well. She came back and the CT showed basically decreased enhancement within the lesion within the liver. And the tumor markers that the oncologist normally checks, all the tumors were markers went down. And this patient, she came to me multiple times for repeat procedures, so that and then we got it to a point that tumor was under control, and she's still alive. This procedure was performed, I don't know, maybe I did this probably 8 years ago now. She's still around. I still see her. Um, so. I kind of talked about ablative therapies already, so I won't go too much into it anymore. So basically, this is a patient who has this is showing renal cell cryoablation in patients who have renal cell carcinomas. Basically, we put probes into the lesion under CT guidance or ultrasound guidance, and then we just apply extreme temperature. So basically, you go through this period where you make the lesion extremely cold using sometimes liquid nitrogen, or sometimes you can use argon, and then you use helium to sort of cool the lesion, and then you make it extremely cold again. And then what this does is that it basically destroys the cell membranes within the tumor, and this ends up inducing apoptosis. And this is largely very curative, especially in renal tumors that are smaller. So a lot of time we like to go after the smaller stage 1 tumors, because those you can actually cure. And there have been many, many, trials that have compared surgical resection with very low grade, or like low stages, RCC, and even sometimes HCC. And the results are basically the same, except that people that undergo surgeries, they end up, staying in the hospital longer, and they have a lot more side effects. In terms of bone cancer, as I talked about earlier on, we would obviously review the imaging. We usually would biopsy sometime. And then in cases where the patients have a lot of pain, we would actually insert needles into the bone. And from radio frequency ablation, sometimes we do cryoablation, we burn the lesion. And after burning the lesion, what we also do sometimes is that a lot of times these patients that, because of the metastatic, they're fractured, we put a balloon. We go through the pedicles, with the probe, and then once you're in there, you get a biopsy, and then we'll put a balloon. And what this balloon does is that once you inflate the balloon, it actually sort of restores some height. Many times you don't actually get to the original height of the bone, but you restore some height and you create a vacuum there. And once you create a vacuum, you can then inject cement, and then you remove the needle and everything else. And these patients, I mean, you see these patients coming with, let's say, 9 out of 10 pain as an outpatient, and sometimes they actually walk out of the hospital because their pain is resolved. Does anyone have any questions so far?
Hi, this is Henry Coleman. We have a few questions in the chat. I think they can probably wait
Okay,
until the end.
Sure. So I'm just going to, and this is the last part. I'm going to talk about the role that we play in women's interventions. So I was in Nigeria, actually, was it 2 weeks ago? So I'm in Nigeria a lot, and and one thing that you notice, even I mean, amongst my own family members, amongst patients who are of African descent, Hispanic descent, that they have a lot of fibroids. Fibroid is a massive problem in Nigeria. It's a massive problem in the US as well. Historically, fibroids have been treated using hysterectomies or myomectomies by our gynecologic obstetric colleagues. But interventional radiology now plays a very, very important role in the treatment um, of fibroids. As you know, fibroids are very benign tumors. They're, located in the uterus. They are very common in patients who are premenopausal. They cause a lot of symptoms, miscarriages, heavy bleeding, um, back pain, mass effect in the pelvis causing a lot of urinary symptoms. A lot of patients experience a lot of pain, bleeding, urinary frequency and urgency. So it, these patients are usually seen by the OBGYN. They usually will go on for hysterectomy. And when you perform hysterectomies, a lot of times these procedures are very involved. And sometimes these patients are not able to have their own children, if they wish to in the future. Historically, the gynecologists would refer these fibroid patients to interventional radiology so that we would help them embolize the fibroids before they go in for surgery. And the goal of the embolization is to reduce bleeding during surgery. However, something interesting happened in France. A gynecologist noticed that when he had sent a lot of his patients to the OBGYN when he had sent a lot of the patients to the IR doctor for embolization, the patient didn't, stop showing up for their surgeries. And this led to him basically calling all the patients and say, hey, what's going on? Your surgery scheduled, are you going to come for your surgery? And the patient would say, well, my symptoms went away. And so I think I'll just hold off for, for now. And this led to that this led to that person writing a paper back in 1995 where he basically sort of published his experience and his findings in these patients. So later on, people started to think about, right now we're doing this procedure as a as a pre-op kind of thing. Why can't we just do this as a primary treatment for uterine fibroids? And this was really when uterine artery embolization started as a primary treatment for fibroid, as opposed to just a pre-op embolization thing, so that the patient can get the surgery done. And right now, I mean, hundreds of thousands, probably millions of women have been treated with symptomatic fibroids in the US and all around the world. So when these patients get referred to interventional radiology, this is what we look at as, we look at the location of the fibroid. We look at the size of the fibroid. A lot of times, if a fibroid is within the uterine wall itself, this has the best fibroids for us to treat, because we can treat this fibroids in its entirety, and there's usually no complications that occur afterwards. Sometimes if a patient has a fibroid that's more sort of pedunculated, and let's say it's subserosal, sometimes we're worried that if we embolize this fibroid could actually sort of slough off and get dislodged in the pelvis and cause infection. So many times we would have a discussion with the OBGYN and say, hey, this is what we're worried about, but we can still do the procedure. However, should this slough off, we may need you to go in and actually remove the fibroid. Now, I have been in this situation probably once or twice in my entire career, where after we have embolized the fibroid, the patient went on to get, let's say, some other surgical intervention. But out of everyone that I've performed, it's very rare that this happens. So patients actually do very, very well. So how do we treat this fibroid? It's the same exact technique that we've used in other parts of the body. We embolize them. The way we embolize them is that we go in through very small blood vessels. I usually perform my procedure through the left radial artery. We basically go into the radial artery, get into brachial, get all the way down to the aorta, and then get into the internal iliac on both sides. And then what we then do is that we look for the blood vessels that are supplying the fibroids. And then once we see the blood vessels, we basically inject very small, tiny embolic material into the fibroid. And then what that does is that it actually causes infarction. It cuts off the blood supply to the fibroid. And then the fibroid dies, and it dies over time, and the patients actually do very, very well. And the only incision that they would have is a pinhole incision, either in the left radial artery in the release or in the groin. And the way we identify this fibroid is that, the arteries that supply the fibroids, they're very sort of like spring-like. And the reason it's like that is because, when a woman is pregnant, these arteries sort of expand and, to help supply the uterus during pregnancy. And when you're no longer pregnant, they kind of shrink back to where they were. So we sort of take advantage of this. And then once we see these arteries, there's usually one on the right and one on the left side. And once you can get into the one on the right embolize, get into the one on the left, you're actually able to embolize all of the fibroids, because all of these fibers are usually supplied by these uterine arteries. Now, you might say, well, if you're embolizing the fiber, aren't you embolizing the entire uterus as well? Well, it so happens that the arteries that are actually supplying the fibroids, they're actually larger than the arteries supplying the actual uterus itself. So when we inject these particles that we inject, they are large enough that they are going to avoid, the small vessels supplying the uterus and only target the ones that are supplying the fibroids. And then this induces necrosis, and patients do very well. And patients end up not needing surgery anymore. And this procedure is very important because in some patients, first of all, because patients can go home on the same day many times, or they can go home on the next morning. And also because some patients, for reasons, religious reasons, for personal reasons, they want to keep their uterus. And this is also important in patients who want to have more children and who are extremely symptomatic. There are patients that their fibroids are so big that it's really affecting quality of life, that the only solution is really hysterectomy, but they still want to have children. Well, in these patients, we kind of counsel them like, hey, listen, we can do this embolization. We can probably, we will be able to reduce your symptom more than 90%. The only problem is that there's also very small chance of an infection. If this infection happens, we may have to have an hysterectomy. And a lot of patients are actually open to this idea because the other option was an hysterectomy to begin with. So this is a normal uterus. This is what it looks like on an MRI. This is the urinary bladder. You can see, very nice and very smooth uterus. And in case of people who have fibroids, this is an example of an anterior wall fibroid, for example. It's a very large fibroid. You can see how it's kind of, pushing the uterus posteriorly. And this is having a lot of mass effect on the urinary bladder here. So this patient, could have gone for myomectomy as well, would have been probably a good candidate, but it's also a patient could have also gone on the go fibroembolization. So this is an example of embolization that was performed. This is a pre-embolization procedure where you can see the uterine arteries have been accessed. You can see them fill. You can see everything that's filling up. After the embolization is performed, you see no enhancement anymore within the uterine arteries. But there's still supply to the uterus, except that the fibroids themselves have been embolized. You can see pre-procedure imaging for fibroids, and post-procedure, you can see all the enhancement within the fibroid is completely gone. Even the size is completely decreased, right? And then you can see evidence of necrosis within the fibroid itself, and the uterine size is smaller. And a lot of these patients, their back pain resolves, the pressure that these fibroids have on the urinary bladder completely goes away, and they don't have to pee. They don't have to wake up 5 times in the middle of the night to pee anymore. And fibroembolization has been recognized by the American College of Gynecology. They actually recommended based on, as an alternative to myomectomies or hysterectomies in patients, who wish to keep their uterus. So, our time is fast spent. So I think I'm just going to end here, and I'm just going to take questions at this point. If you have any questions about anything that we've talked about. Thank you very much. So if you have any questions, I'm happy to take them, if you can hear me.
Well, thank you very much for this wonderful presentation. There's a lot of information, and for us who are not in the interventional radiology field, especially people who are not from a radiology background, this may be a lot of new information. I'm going to start with, we have a couple of questions in the chat room here from Dr. Kingsley. The first question is, how come, so this is related to the variceal bleeding that you talked about. There was an elderly man who was not a candidate for endoscopic treatment, but he was a candidate for IR. The question is, why was he not a candidate for endoscopic treatment, but a candidate for IR treatment? And was IR not done under general anesthesia?
Yes. So yes, thank you very much. That's a very, very wonderful question. So a lot of all our referrals for these TIPS procedures, they actually come from the gastroenterologist. A lot of times, this patient would have undergone banding. They would have undergone all sort of procedures before they actually come to us. A lot of times they come to because their procedures have failed. Either they underwent banding and then the patient rebled, and then they sort of in this particular patient, he had a lot of rectal bleed, and they did a scope, and they couldn't really. The other thing was that they were also afraid to touch it because they were afraid that if they got into like a rectal bleeding that's caused as a result of portal hypertension, they would not be able to stop it. They would not. If it were to be like an arterial bleed, might be easier to stop. But if it's caused by portal venous hypertension, the only way to stop that would probably be to try to decrease portal hypertension. And the way to decrease portal hypertension is to put a TIPS stent in. So thank you. Yeah, and the TIPS are performed under general anesthesia because they can be very painful, and you need the patient to be sort of still when you perform them.
Thank you very much for that answer. The second question, also from Dr. Kingsley, is do all IR centers in the US offer all the IR services listed, or does it vary among centers? What about yours?
Yeah, so it definitely varies among centers. But you'd be surprised, a lot of them do actually offer many of the services with regards to, when you talk about like fibroembolization and the ablations, these are basically sort of like standard IR procedures that I would say majority of centers actually offer. Now, when you start getting into procedures such as a TIPS procedure, putting a shunt within the liver, those are not offered everywhere, but a lot of I mean, these days a lot of hospitals actually offer this procedure. I mean, I'm close to Pittsburgh where I am now, and we probably have, I don't know, 20 hospitals in my region within probably 50 miles from me. There are probably 20 hospitals, and I can't think of one that does not offer that service. Because a lot of these new interventional radiologists coming out very, very, they trained on this stuff in fellowship, and they're very, very enthusiastic, and they want to get this done. And they are not, from our standpoint, they are difficult procedures to perform, but they are also not as difficult to perform, if that makes any sense. Like if you've done a few of these, they are not that complicated because you can actually see everything you're doing on the real time ultrasound, and X-ray guidance. And like I said, we use basically the same techniques in every body part. So many, many centers, more than you would think, actually offer these services.
Thank you very much for that answer. Are there any other questions? If you want to ask the question directly, you can also raise your hand. Okay, I have a couple of questions. So
Sure.
I'm also from a radiology background, and I think there's quite some overlap in neurointervention and vascular interventional radiology.
Right.
At least in the community setting, there's quite a few providers performing neurovascular procedures. I know many people who perform thrombectomy for stroke, for example. Kind of in general, among people where do you think this is going? Are interventional radiologists excited about doing thrombectomies, or is it more something that people are asked to do, but they're not very interested in doing it?
Yeah, so so in terms of the interventional neuro procedures in the community settings, you see some people who perform thrombectomies and stroke interventions, but in the IR community, you would see that not a lot of people not a lot of people want to do it anymore, because at many centers, I mean, many people live within 50 miles of a stroke center now. And obviously, there are also the interventional neuroradiologists or interventional neurologists who are also very, very much involved in this space. So, and I would say that in the future, or even though the SIR is really trying to encourage IR doctors to get involved, I've not really seen a lot of enthusiasm in that regard. I've seen people focus more on everything else below the neck, more than they do the intracranial procedures, especially because if you're at a center where there are neurointerventionalists, there's no reason for you to be doing it, because they would do more of this than you do, and they're better trained in this regard. However, if you're in a place where you are the only one, or there's no one else available to do it, then you would do it. I'll even give you the opposite example. If you're at a large academic center where they have 10, 20 IR physicians, sometimes these centers, they have doctors who only focus on one thing. And someone might say, well, I'm only like a women in interventions person, and I'm only going to do fibroids. I'm only going to do PAD. So it really depends on the center. But my general sense is that most IR doctors in the US avoid doing intracranial interventions, because there are other specialists who can do a better job, and they do more of it. So,
yeah, thank you for that answer. Yeah, I agree, but people tend to like subspecialize more and more.
yeah.
I think sometimes it can be actually a benefit to have more people involved.
Yes.
For example, I don't do interventions below the neck so much, except for the spine. And when I come into an unusual situation, I often ask my IR colleagues, and they've been into similar situations in other parts of the body, and it can be very valuable with that input. And people are trained, for example, in neurosurgery or neurology, who have not gone through the IR pathway, have not been exposed to how you do things in other parts of the body. So I think, to some degree, I think it's very valuable to not have a complete separation between the specialties also.
Yeah, and then the other thing is that, a lot of things that we perform are always, I mean, we try to be very collaborative with other specialties, because you really can't do the stuff by yourself, and you really can't do it alone. Because there are some cases when, I mean, so sometimes you get a call from the interventional cardiologists or the vascular surgeons who run into issues. Sometimes we run into issues, and we also call them. I personally have learned a lot from our colleagues in other specialties. As a matter of fact, it was one of my vascular surgery friends that got me started doing, mesenteric stenting, for example. So there's just a lot to learn from one another, and there's no one who can go at this alone.
Yeah, thank you. Yeah, one example from neurointervention that people in the call may be familiar with is the problem of intracranial stenosis, which is a problem that's not really solved to this day. There was a lot of efforts a few years ago to develop intracranial stents for intracranial stenosis, and there was a big trial that failed. So this is something we don't do frequently, but recently people basically used a solution that cardiologists developed with balloon-mounted stent and extrapolate that to the brain, and it seems like that is very effective. And if someone makes a trial, that the treatment may change. So if you're involved in the neurovascular field, I think if you want to be on the forefront, I think it's very important to stay in touch with endovascular treatments of other parts of the body, and you can adapt things and be on the forefront in neurointervention also.
Yeah.
Any other questions? Okay. Well, thank you very much for this presentation. It was very useful for all of us. And if we don't have any additional questions, then I'm going to hand the microphone back to Dr. Bankley for closing this session. Okay. If Dr. Bankley is busy, I will just close the session here, and again give my best thanks to the speaker, and it's very good for me to be able to participate in this and have all of you in this presentation, and I'm very excited to continue to develop, be a part of the WASI collaboration, and develop the everything good we're all doing. And thank you very much for listening in.
Thank you very much. Thank you so much for having me. Appreciate it very much. Thanks, everyone.
Thank you.
Thank you.
Goodbye.
Goodbye.
Thank you and goodbye.